It is really a pleasure for me to be here this afternoon with members of the Western Neuropathy Association. I think this is a wonderful association and it's helping a lot of people. And I'm going to talk today about a controversial issue. Well, starting with a provocative question, the Sudoscan. And the question is this a final answer to the question of small fiber neuropathy? Is actually bringing a provocative subject in itself, the subject of small fiber neuropathy. So as a way of breaking the ice, I would like to know a little bit have some feedback from the audience in terms of what is your understanding about small fiber neuropathy. First of all, have you ever heard of small fiber neuropathy before coming here? And what is your understanding? So please don't feel embarrassed and just raise your hand and say, well, this is what you want to comment?
Oh, no, I don't know.
Oh, okay. All right, go ahead. So,
on that t-shirt, which I'm wearing, you have a new expression, and you have a long axon that comes from the back, the spine, and then you have a little unmyelinated axon is myelinated, and then you have a new small fiber down at the end that are not myelinated. So I wear the illustration of what small fiber neuropathy is. And if you buy one of our t-shirts, you can wear it too.
That's really wonderful. And any other comments from the audience? Okay, all right. I'm going to bring it to this lady that is a little bit far away. Okay. Too bad that we don't have a second device here.
I was just diagnosed last year with peripheral neuropathy. So I have no information about the small fiber neuropathy or what even caused it. It happened and the doctors worked on finding the correct medication. So for me, this information about the small fiber neuropathy and what causes neuropathy is a brand new topic for me. So I have no information about what's being discussed here except when Sonia, the pharmacist, talked about the medication. So this is very informative for me, just being diagnosed last year.
Okay. Okay, thank you for your comments. There was somebody else here that wanted to make a comment here. Okay.
So after when the two doctors, two neurologists, I thought we went to this other one who was somewhat of an expert, and he said, there's many kinds of neuropathies. He said that you have small fiber. He said it's not peripheral neuropathy, it is small fiber neuropathy. He said, and you're not going to die from it. And then he went on. And he said that, your small fiber, he said, is different than peripheral neuropathy in that your muscles are not going to get weaker. Perhaps your he said you perhaps will have numbness in your legs. He said it very rarely goes up to your arms.
That's right.
And he told me I should go out and walk as much as I can.
Okay.
And then he said, and don't come and see me again because you don't have a serious neurological condition.
Okay. So does everyone agree with that, what the doctors say? Probably that I don't agree, right? If it is your disease and you got a problem, it's a problem. It's not really ignoring that really won't help, right? So, but what I'm seeing here, what I'm hearing is there's a lot of different views of what neuropathy, small fiber neuropathy is. And we have here a test that I'm introducing to you. And by the way, I don't have any conflict of interest, so I will not try to sell you a Sudoscan system, okay? But at any rate, it is indeed a very provocative subject, small fiber neuropathy, because as Marilyn pointed out, many doctors believe that that's not a real problem, that you're not gonna die and it's not a serious problem, and then probably somebody else should take care of the problem. And so that is not really what I don't agree with that. So I don't have to introduce to this audience these symptoms, right? Loss of feeling, freezing, tingling sensation, vexing tingling sensation, sharp pain. Sometimes the minimal contact with the sheath of the bed will trigger tremendous amount of pain, okay? Burning sensation, numbness, etc. Okay, so this is really what small fiber neuropathy is. Some of the symptoms of small fiber neuropathy, although you can have this with large fiber neuropathy as well. And then the other thing that is really well exemplified here is that it's more prominent in distal part of the body, in the feet, right, in your hands. Very rare neuropathy will start in your hips or in your shoulders, okay? So the concept is that neuropathy is a problem that is produced by a problem in the nerves that is length dependent, okay? The larger, the longer the nerve, the more likely to be affected. So your symptoms will start in your feet, okay? Because it's a length dependent process. To our medical students, we teach them that it's also a process of dying back, a process that we call Valerian Degeneration, which means that if the nerve is affected distally, there is a process, a retrograde process that starts chewing the nerve back, okay? So the nerve is being degenerated in a back way, okay? And then somebody mentioned, Bev mentioned about the myelin and the axon, okay? So there are fibers, the large fibers they have an insulation that's called the myelin. Everyone knows that, right? The myelin is good because it allows the nerve to function in a way of transmitting impulses very fast, okay? The more myelin, the thicker the myelin is, the faster the nerve conducts, okay? And then when there is a problem in the myelin or in the axons, then you get this situation. You got a problem, the degeneration of the nerve, and the problem with the nerve, it could be many reasons for the problems in the nerve, okay? Maybe you have antibodies. You have a flu illness, and then a couple of weeks after, you develop antibodies against the virus that cross-react with the myelin, and you have a disease that's called Guillain-Barré syndrome. Everyone knows what Guillain-Barré syndrome is, right? It's the disease of the myelin. Or maybe you have it in your genes. The proteins that are needed there in order to construct the myelin, your genes carry mutations, and that's coming from your family, okay? Or maybe you had diabetes, okay? And the diabetes, I will show this because diabetes is one of the most common causes of neuropathy, okay? And what is the pathogenesis? What is the real cause? Why diabetes impact the function of the nerve? And the reason of that is that this is a normal nerve. The nerve needs vascular supply, okay? And the vascular supply in a normal situation comes from something that's called the vasa nervorum, which provides very tiny arteries that goes to the inner part of the nerves, okay? And supplies all the nutrients and vitamins and things that the nerve need in order to operate properly, okay? Now, if your sugar in your blood is continuously high because you have diabetes, the sugar in the blood, you have proteins. So the sugar and the protein, they get together, okay, and create like a gump, okay? And that gump gumps like a substance that is not really, is precluding a proper circulation in these very tiny arteries, okay? And so that really is producing an obstruction of the flow of blood, and so the nerve is not receiving the proper nutrients, okay? And so then you have the pathogenesis of diabetes, which is one of the most common causes of neuropathy. So, and we have a wonderful test for nerve testing, okay? And I'm sure everyone here, I had the test of nerve conduction study, and probably everyone here in this room had a test of nerve conduction study, which is a great test because it can measure the signal from the nerves. If those signals are delayed, we can tell that there's a process with the myelin. The nerves maybe are not conducting fast enough, right? Or if the signal is very small, we may be thinking in terms of an axonal part of the nerve that is damaged, okay? Now, as Marilyn pointed out, maybe she had this test and the test was normal. And what was in the past, we say, well, you don't have a neuropathy, okay? But the patient will come and say, well, but I do have the symptoms, right? So it got to be an explanation for those patients that have normal nerve conduction velocities, still symptoms of neuropathy, okay? So here's what happened is that in the skin, there are very, very tiny nerves, okay? And those nerves are so small, they are not myelinated. They don't have the insulation, okay? They're very, very tiny, and they come from very important parts, like Meissner's corpuscles, which are mechanical type of receptors that allow us to feel the pressure and the touch, and Pacinian corpuscles also that give us all this information that we need that coming from the skin that let our brain to process this information that comes to us, okay? And so, but all of those are very tiny nerves that are coming from the skin or going to the hair or to the sweat glands, okay? So all of that can be damaged independently from the damage of the nerves, okay? And we call this small fiber neuropathy when this is affected. And going back to the process of the pathogenesis of diabetes, this obstruction of the arteries can affect the arteries that go to the skin, okay? So those very tiny arteries can be occluded and then affect the function of these nerves that are coming from receptors and control the normal operation of the sweat glands and the sebaceous glands, okay? So, small fiber neuropathy, by definition, is a type of peripheral neuropathy that occurs from damage of a small unmyelinated peripheral nerve fibers, okay? And it's really, in a way, is fortunate that we have now this term, but it's a little bit unfortunate as well that we are stuck with the term of small fiber neuropathy. In part, doctors, we don't like that term because it is difficult for us to make the diagnosis, because we really don't have any good test to say, well, indeed, you have a small fiber neuropathy. It also overlaps with diseases that we really don't understand. Diseases like fibromyalgia. I'm sure most of you might have heard about the term fibromyalgia, or reflex sympathetic dystrophy, or complex regional pain syndrome. Diseases for which we really do not have any pathogenic basis that we can easily, for us, demonstrate that the pathogenesis is there. And then most important, as I said, we really don't have a good test to demonstrate that. Then patients, in a way, they like it because now they have the term small fiber neuropathy, but the ultimate question is, well, what can we do about it? And most of the time, doctors will say, well, we cannot do much about it, right? So that is a vexing problem. Many times, the small fiber neuropathy results from diabetes. And then what is the answer? Well, control of the diet, control of the sugar, things that are really difficult, okay? And most of the times, the disease cannot be reverted, okay, cannot be corrected. So, going back to the question of the doctors, how do we make the diagnosis of small fiber neuropathy? Well, there is a test that is called quantitative sensory testing, which is a test that we delivers certain amount of stimuli in the feet or in the hands, and then we ask the patient is he feeling the input or not, and then we'll kind of do a quantitation of what the patient is saying to us. But as you can see, that is a very subjective test, including pain or including touch sensation or many modalities of sensation. For instance, my grading of pain 8, for instance, would be different from Marilyn, would be a 6 for her, and for somebody else would be 4 or 2. Okay, so there will be, when you're really depending on subjective elements, you cannot really be completely sure what is really, what is the real grading. So there is another test that is called Intra-Epidermal nerve fiber density. Have you ever heard about that test? Anyone? Okay. So this is really a popular test, and is actually, I would say, is the gold standard for small fiber neuropathy. Because what it is we take a punch biopsy of the skin, and we look in the microscope for the small fibers, okay? So this is a really very objective test, and is a gold standard for making the diagnosis of small fiber neuropathy, okay? And although it's a gold standard, there are some problems with that test too, which I will cover in a second. Now, there's a way to go around the fact that, one test is very subjective, the other test is a little bit invasive because you need to do a skin biopsy. So one way that we have been doing for many, many years, more perhaps 50, 40 years, testing autonomic function. And what is autonomic? Autonomic functions are the part of the nerves that control things that are autonomic, that are not really controlled by our voluntary system, okay? Like sweating. Sweating is out of control. We sweat because our autonomic nervous system. Our heart beats independently of our feelings or whatever we're thinking, okay? This is autonomic, okay? And so, as I pointed out to you, the nerves that supplies the sweat glands are very, very tiny nerves. So, if we can demonstrate by test of autonomic dysfunction, malfunction of small fibers, then we can make the diagnosis of small fiber neuropathy. So that is the concept. So first of this test is the quantitative pseudomotor axon reflex test, which is a test that was developed in the Mayo Clinic about 40 years ago. And it really what it involves is putting a small chamber in the skin and forcing a substance, which is acetylcholine, and acetylcholine activates the sweat glands, and then through the other part of the chamber, circulating either air or nitrogen and looking at the humidity of the air that is passing through the chamber. So that's one way to do it. It's kind of a cumbersome. I have done this test many times. I used to do it when I was at the University of Chicago. But as I said, it's a little bit cumbersome to do it, a little bit messy because you need to put a substance on the skin. And so another test that you can do, so this is not really very popular. We're not doing here at the medical center. And there is another test that is called the sympathetic skin response. And the sympathetic skin response is to deliver certain amount of current to the skin and see what happened with the voltage of the skin. If the skin, the resistance of the skin is changing, the voltage is changing, okay? And we can measure with a machine that change of the voltage. In a way, it's the same principle of the lie detector, okay? So if you're lying, the principle of the lie detector is if you're lying, you will have a change of the resistance of the skin, okay? Why will happen? Well, because there is an emotional component when you're telling a lie, right? So that's the principle of the lie detector. And the lie detector measures the resistance of the skin, whereas here we measure the voltage, okay? One of the problems is that this sympathetic skin response is you really cannot do a quantitation very easily. It also habituates, meaning that if you do the stimulation several times, eventually it disappears, right? So that's not really a very reliable test. And so we have moved about 2 or 3 years ago to the Sudoscan, okay? And I will introduce it to you, the Sudoscan. But before going that, I was just going to say a few words about the intradermal nerve fiber density, which is entitled or involves a punch biopsy, which you do it distally and proximally in the leg. And I had to tell you, I have done several of this, and really it's uncomfortable, it's painful. Although we put numbness there, you know, not only that, it's kind of it's painful. It can potentially be complicated with infection, not very often, but that is always a possibility. Anytime that we break the skin, that can happen. And then that's what it shows. It shows, you know, we can do special techniques to stain the nerves, and we can measure in the millimeter, square millimeter, the amount of nerves that we see. And then that would be a case of a normal fiber density, another case of a diminished fiber density, okay? The problem with this is that sometimes you do this test and it comes back with the result of mild decrease of fiber density, and we don't know how to interpret mild decrease of the density. Is that truly neuropathic or is not? Is relevant to the patient or not? So, and then you're talking about an invasive test. So we're just thinking about that perhaps the Sudoscan being a very fast test and a test that can be used as a surrogate of the skin biopsy would be an appropriate test for patients with symptoms of small fiber neuropathy. And here is the Sudoscan. This is how it looks like. It's a very small computer, as you can see, and then you can see these big plates. So you put your hands on the plates, and you stand up in the feet plates, okay? And you do that for 3 minutes, okay? And during the 3 minutes, one important thing, you don't have to move. If you move, it will alter the result, but you have to be standing still for 3 minutes. And what happened is that you will deliver, the machine, the plates themselves will deliver a small amount of current, okay? And so, since the skin is not conductive, because we have the epidermis, right? The epidermis acts like a big capacitor. It really charges electrons, but the electrons don't go through, right? Small amount of electrons go through whatever pore is open in the skin. And the pore that is open in the skin is the sweat glands. And the sweat glands have chloride and sodium, electrolytes that conduct electricity. Okay, so depending on how good your sweat glands are, then the conductivity of the skin will increase. Okay, and so we can do quantitation of that. And so if your nerves, if you have good small nerves that are going to sweat glands, and then you have proper amount of chloride in the pore of the sweat gland, then your skin conduction will be good, okay? So you will be within the normal range in your feet and in your hands, okay? But if you have a small fiber neuropathy, either because you have diabetes or you have whatever is causing damage of the small fibers, it will damage those very tiny nerves, and then the conduction, when you deliver the voltage of 4 volts in the skin, that will not go through, okay? The conductance of the skin is decreased, okay? And we can do quantitation of that, all right? So this is the principle of the test. And it sounds wonderful because it's very simple. It really doesn't take, it's really completely painless because you don't even feel the electricity going through your hands or your feet, okay? So we can just say, well, take this face value and say, well, this is a wonderful test, we will do it. And although that's not the philosophy of university centers, right? We really need to test, we really need to collect our own data and to make sure this is really what we're saying that we're trying to accomplish is being accomplished by the system, okay? So we have collected, by now we have about 150 patients that had a Sudoscan. And the analysis was done in about 100 patients, 99 patients. The age, the mean age of the patient, 53 years old, 53.2. And this is a typical age of starting with a small fiber neuropathy, okay? Kind of late middle age, started with those symptoms, median age 55, but a wide range, because you can see patients starting with these symptoms very early in life, in children even. I have done, and in the youngest patient I have done a Sudoscan was 4 years old, a patient with diabetes. So here's what the data showed, a little bit more common in women than in men, okay, you know that too. And here's what the data shows. If you go and you have the test, chances are that it's going to be 1 out of 2 is going to be normal. In other words, 46 patients in whom we did the Sudoscan out of the 99 patients were normal. So about half of them, half of the patients were normal, okay? 24 patients were abnormal, both in feet and hands, okay? And then there were discordant findings, like abnormal only in the feet in 3 patients, and abnormal only in the hands in 7 patients, and discordant meaning that it was a normal maybe in one hand, but the other hand was okay, feet were okay, and so on and so forth. One thing that is odd already is this, the fact that it's more commonly abnormal in the hands than in the feet. And if you remember what I told you at the beginning of the talk, that normal neuropathy is length dependent. So you would expect the test, if it were length dependent, to be more common in the lower extremities, in the feet. Do you understand what I'm saying? So that's a little bit something that kind of triggered our curiosity, why this is more abnormal in the hands and not in the feet. So it doesn't really, the first thing is that we started to notice that this really doesn't follow the pattern that we see in neuropathy, clinically or by doing neuroconduction tests, okay? Now, and let's put it in a bar graph. So out of the 100, half of them were normal, okay? Abnormal, about a quarter of the patients. Then abnormal in the feet, just only in 3. More than half, more than double of that abnormal in the hands, and kind of a discordant pattern in about the similar, almost about 20 patients. So that's the data. That's what the data showed. So let's concentrate in those who have. Yeah, go ahead.
Were all the patients tested symptomatic?
Yes. Yes, I will cover that. All the patients had the symptoms that I referred in the first slide. Burning sensation, tingling sensation, that sort of thing. And there was no difference on those who have a normal or normal test. Okay, so we'll say that, yes?
Discordant means what? Inconsistent?
What's that?
Discordant.
No, discordant, the only thing that it means is that, as I said, we have maybe one hand that is abnormal, and then the other hand was normal, and the feet were normal or abnormal. And so we play very conservatively this and only report the test as abnormal if we see consistently, both in hands and feet, okay? So discordant is a group that say, well, maybe or maybe not, okay? So let's concentrate on the group that the test was abnormal, okay? And the mean age was 63. So one thing that really is obvious, that this group of people were older, okay? So if you go back to the previous one, the mean was 53, okay, with a median of 55. Here the median was 67. So clearly 12 years older, okay? So what it means that as you're getting older, your chances to have an abnormal test increases. And that makes sense, right? Because as we are aging, our nerves are becoming less dense, right? So that really makes sense, okay? So that's one thing that was something that we saw. Then as in terms of the symptoms, or numbness, tingling, burning, and asking your question, those were the symptoms, but as I said, no difference between the group that was positive and the group that was negative. Now, fasciculation, muscle cramps, kind of symptoms are really non-specific. You wouldn't expect to find this to be abnormal. That was what the data show. Whole body paresthesias, and paresthesias mean numbness in the whole body, okay? Well, that's for one patient. And trunk paresthesias, yeah, no pattern. It could be the whole body, it could be the trunk, and also symptoms of syncope, okay, which makes sense because there's also, depending on the autonomic nervous system, our blood pressure, okay? So we have a sudden drop of our blood pressure. It makes sense it will correlate with abnormal autonomic nerve function. And as you know, and Parkinson's disease in one patient, and you might have heard some patients with severe Parkinson, they can have problems with controlling the blood pressure, controlling the postural, the blood pressure can drop very suddenly, okay? So they're telling us a patient with severe Parkinson's disease can have problems with the small fibers. So, and this is really the most important things that I would like to transmit to you, that out of the 24 patients in whom we found the test to be abnormal, 5 patients have diabetes, okay? Whereas only 5 patients from a total of 46 patients in the normal control have diabetes. So here's one point, is that your chances to have an abnormal test if you're diabetic increases double. It also makes sense, okay, totally sense. It makes sense that if you're old and if you have diabetes or pre-diabetes, just a little bit of the sugar increase in your blood, this test may be abnormal. Those are 2 factors that really make sense, okay? Now, one thing that is also surprising is that out of the abnormal, the nerve conduction, there was no correlation with the test of nerve conduction, the classical test of nerve conduction, right? 6 out of the 24 has an abnormal nerve conduction velocity test, whereas in the group that have normal Sudoscan test, the nerve conduction velocity was abnormal in half of them, okay? So abnormal nerve conduction velocity in a quarter of patients with a normal Sudoscan versus abnormal nerve conduction velocities in patients that have normal Sudoscan. What it means that there is no really correlation, and the fact that your nerve conduction velocity is normal or abnormal doesn't in no way predict if you're going to have a normal or abnormal Sudoscan. And I'm going to skip that because those are tests, are scientific tests that shows the value of this test performed by, this is a group in the UK that shows there was a very good correlation between the Sudoscan and symptoms of neuropathy. This is in 45 patients with type 1 diabetes. And not only they demonstrated there was a good correlation with the symptoms of neuropathy, but there was also with the symptoms of cardiac dysfunction, because as I pointed out to you, the control of heart depends also on the autonomic nervous system. And also they demonstrated correlation with symptoms and also correlation with symptoms of abnormal cardiac function. And this is another study. This was performed here in Iowa by Gordon Smith. I know this neurologist personally, and I know that this has come from a very solid group. And also showed again that there was a very good correlation with Sudoscan and symptoms of diabetes. And this is the bottom line. Sudoscan is a promising diagnostic test for diabetic type and idiopathic type of peripheral neuropathy, distal peripheral neuropathy. And there was a good correlation with these other invasive tests, as I told you, the intradermal nerve fiber density test. However, there is a test that really is not, that was a more recent study from Michigan, Ann Arbor, that in fact showed no much correlation between the Sudoscan and symptoms of autonomic dysfunction like syncope, syncopal episodes, that sort of things, symptoms of cardiac dysfunction. And so this was performed in a group of patients that were relatively young and patients with diabetes type 1. And so in no way this single study that I show you here, that show no much correlation, it proved that this is not a test that is not effective. It's just simply, I just wanted to show you the two sides. Those are in favor, and those are the ones that didn't find much correlation. Okay, so, and here are the conclusions, okay? We can open then the discussion. The conclusion is Sudoscan is a fast and objective test of autonomic sympathetic pseudomotor function, okay? Why I'm saying that it's fast? Well, this is really a fact. It's a very fast, painless test we can perform in the laboratory, and really it's an effective test. In terms of, is an objective test? Well, I think this is based on the fact that it's more frequently abnormal in elderly people and in patients with diabetes. And there are two factors that are telling us, we know those factors by pathology, that those correlate with small fiber neuropathy, and that's what we found at the medical center, that it correlates with these two factors. The other thing that we found that there is little correlation with conventional electrodiagnostic tests. So if your doctor tells you that you have a normal nerve conduction velocity test, in no way he is ruling out small fiber neuropathy. And if he is to perform this test, in no way normal nerve conduction studies will predict what would be the result of the Sudoscan. And then also support the fact that at the beginning I told you that a neuropathy is a length-dependent process. Either myelin or not in the myelin on the axon is a length-dependent. The longer, the more chances to have a problem. Here is not length-dependent, okay? Here, the small fiber neuropathy, first of all, can start any place. Not necessarily, it's more common in the feet, but really can start, I've seen many patients starting with symptoms in the back or in the patch of the skin in the thorax or in the chest, okay? So the pattern could be very variable. And well, evidently, additional prospective studies are needed to validate the reliability of the test as an indicator of small fiber neuropathy.